Hi, everybody. Like she said, my name is Juliana Wulforst. I'm a PA. I work in general surgery and trauma at WakeMed, not too far down the street from us now. Before I tell you more about my project, I kind of want to just set the scene a little bit, give you a little bit of a day in the life as a trauma PA. So if I could ask you all to kind of close your eyes and imagine that you're, maybe up on the floor in the hospital, rounding on your patients. Maybe you're in the ICU with a patient who's intubated and sedated, talking to the family about goals of care. Maybe it's 3 o'clock and you're just sitting down to eat lunch for the first time. Pager goes off. Trauma 1, ETA, 5 minutes. For us, the care of the patient starts right now. Before they've even hit the door, we start thinking about what we're doing, how quickly we can get downstairs, what are the resources we might need, who's around, if the trauma surgeon's in the OR, if we might need to call the backup surgeon. Even though they're not even here yet, we're thinking about how we can care for them. For us, this is very routine. We do this 10, sometimes 20 times a day. But for our patients, this is anything but routine. These few minutes often represent, a shift in the trajectory of their entire life. Here's your hypothetical patient, 21-year-old, status post-MVC, past medical history, anxiety, PTSD, long list of injuries here. This is a pretty typical polytrauma patient for us. You could hand this slide to a trauma provider anywhere across the country and they'd probably spit out a similar treatment plan. Also of note, her alcohol level was 0.204 on arrival, which if that changed the level of sympathy you feel for this poor girl, I encourage you to make a mental note of that. We do a great job of treating these physical injuries. Anything we can feel on a physical exam or see on a CT scan, we're pretty good at what we do. We don't do a great job of treating the injuries that we can't see, some of those psychological injuries. Within a year of a trauma like this, 23% of patients develop depression and 21% develop PTSD. Although currently across level 1 and 2 trauma centers, we're only screening for depression in about less than 25% of these trauma centers are screening for depression and 7% are screening for PTSD. This is unacceptable. But my project this year is hoping to make a step in the right direction. I've been working on the implementation of a post-injury mental health screening and intervention tool at WakeMed. What do we use for this? The ITSS, or Injured Trauma Survivor Screen, is one of the tools that has been proven to be the most effective for this use. It measures for both PTSD and depression, while some tools only measure for one or the other. It is intended for the acute care setting while someone is hospitalized, and it has established validity with excellent sensitivity and specificity. One of the disadvantages is that it's not validated for our pediatric patients, so we still have some work to do in terms of getting them proper screening and intervention post-trauma. You can see it's a 9-question screening. It's kind of divided into questions based on before the injury, during the injury, after the injury. Anything a 2 or higher is a positive screening. You can screen positive for either depression, PTSD, or both. How and when do we implement this? Throughout this year, talking to different people with our team, there was a lot of discussion about whether this should be administered by a clinician, one of the physicians or a PA, or whether it should be administered by a nurse. And kind of like we've talked about a little earlier today in the conference, we just don't have the bandwidth to administer these things ourselves. So we came up with the idea that we should utilize the technologies that are already at our fingertips. Most of our patients have access to a smartphone. Those who don't could be provided with an iPad that all of our units already have. And we could administer the screening tool online through Epic. Obviously, it's important that it's done through Epic so that it's encrypted, and since it contains sensitive patient information. But that way the patient can kind of do it on their own time. They can do it in their own privacy because these are, of course, some sensitive questions. The nurse can help them set up with this tool the same way that they help them get set up with Epic. And a positive screen would then trigger us as the provider to place a consult to our behavioral health team. The behavioral health team can then, do a more in-depth assessment and determine whether they need outpatient resources, or maybe they need a psychiatric evaluation from a psychiatrist while they're still inpatient. The plan is for us to run a pilot at WakeMed this spring. If any of you have ever tried to get integration of a tool with Epic in your hospital system, it is a very work-heavy process that has a lot of kind of kinks along the way, so that process is still ongoing. But if nothing else, we're going to be at least doing a paper screening in the form of a paper form this spring at WakeMed to kind of establish some of the validity of it for us. But the hope is that, like I said, to eventually get it integrated with Epic, and as it continues to increase the automaticity as much as possible. So that orders included on the trauma admission order set, every patient gets administered this screening, any positive screening just automatically triggers a consult to a behavioral health team, and so on. Why? So as Dr. Fakhri said in this quote, our trauma systems are failing to provide comprehensive care or look at the ultimate outcomes of our patients. Like I said, we do a really great job of caring for physical injuries. We can fix bones, we can suture things inside the abdomen, we can take out organs, and we can say that we repaired people. But unfortunately, we're missing a key piece of that puzzle that is important for their quality of life, as opposed to just life itself. As you can see from some of these statistics, this is at 2 months post-trauma, 44% of people had not returned to work. I can't imagine what that would do to me socially, emotionally, financially. 50% screened positive for PTSD and depression. 35% considered getting help, but only 10% did. 42% didn't even know where to get help if they wanted it or needed it. And when asked about if they had received information about coping or what kind of emotions to expect post-trauma, most people answered no or I don't know. Of course, a lot of these things are multifactorial, and I'm not saying that this screening will fix all of them, but I am confident that we can increase the percentage of people getting professional help, considering and receiving professional help, and that we can make sure that all of our patients know where or how to get help if needed, and that they can all answer yes when they are asked if they received information about what kind of coping or emotions to expect. Another reason why is the American College of Surgeons Committee on Trauma is going to start requiring it for all level 1 trauma centers. So my reason why is a little more personal. This patient that you saw on those earlier slides is my big sister, Christina. She had some undiagnosed mental health challenges that she self-medicated with alcohol. Unfortunately, that led to this accident. Luckily, she didn't hurt anybody else. But her hospital team and her team after hospitalization did a great job of caring for her physically, but there was nothing done to address her mental health. I think it seems pretty clear to us now that, obviously with her underlying mental health history and coming in with a positive alcohol, that, what better time to intervene on someone's psychological health. But I'm forever thankful that they did such a great job of taking care of her physical injuries. But how could we not expect this girl who already had this underlying history, goes through this significant trauma, is now feeling immense guilt for what she's done, is facing legal consequences, may go to prison, is facing over $1 million in medical bills because insurance refused to pay for the injuries that were sustained during the commission of a crime, is wheelchair bound because she can't walk, is living in a hospital bed in her parents' dining room. How could we not expect her to have further mental health challenges? It took a few years, but she eventually got the help that she needed on her own. She got into counseling, she got on a medication that changed her life, she found a spiritual community that has also been life-changing. She's brilliant, she's generous, she's driven, she's the person I admire the most in the world. But it makes me so sad for her that she had to wait for years, in which time she spent, always doubting herself and feeling guilty and feeling like she wasn't good enough, and at times suicidal because we didn't properly set her up with the care she needed when she left the hospital. So I'm hoping that this project certainly changes that for Wake Med in the coming months and that it helps set the framework for trauma centers in our area to do the same. Thank you so much.